Naas General Ireland since January 2022. Prior to returning to Ireland, he worked from 2016 as a consultant radiologist in Vancouver, Canada. He is a fellowship-trained neuroradiologist and also holds a fellowship in magnetic resonance imaging, both from University of British Columbia in Vancouver, Canada. He currently works as a general radiologist with special interest in neuroradiology or stroke, MSK, sports medicine, and non-vascular interventional radiology. But mostly, he's a busy dad of 3 small children, and he apologizes in advance for any potential background noise as it's getting near their bedtime here in Ireland. Today, Mark will talk to us about how stroke care has evolved over the past 15 years and how radiology has played a pivotal role. Over to you, Dr. Mark Harmon.
Hi, everyone. Hopefully you can hear me. Thank you very much for the introduction, and thanks to Atu for inviting me to talk to you tonight. So I'm going to talk about radiology and how it has been pivotal in the evolution, or really the revolution, of acute stroke care around the world. And it'll be, I have no disclosures. The layout of it, it's a little bit intertwined. How the stroke management has changed over my career, just kind of highlighting that things weren't always as they are now. And it took a long time for things to get to where they are and the various landmarks along the way. And talk a little bit about why we do the imaging we do and why it is so important. And then the next steps along the stroke pathway. And I do all this bearing in mind that resources aren't the same everywhere around the world. And this is me in 2005 in Livingston Hospital, where I spent 6 weeks as a medical student. And even on the small island of Ireland, the treatment pathways are very different in different parts of the country, depending on where you live, because the access even in Ireland isn't the same everywhere. But what's really important with all of this is the need, wherever anyone works, is that there should be a champion or somebody to lead a service, because no matter where you are, affecting change is very hard. So I'm going to go back to 2007. And in 2007, I had just finished med school. I was working as an intern in Dublin, and it's around now that I think was really the beginnings of the stroke revolution when you look back on things. In final med, we had learned about the concept of thrombolysis and stroke, but really it wasn't really happening on the ground. I certainly wasn't seeing it as a med student or as an intern. There was very limited time windows that people talked about, up to 3 hours. The drugs were limited. There was no pre-alert system from the ambulances, no proper pathways when somebody with a stroke came into the hospital. And in 2008, I was a senior house officer, and I was then in the thick of things, admitting cases through ED. And very, very infrequently we would see a thrombolysis, but it was very fragmented, very haphazard. But the data was starting to emerge, and the ECAS-3 trial, which was published in 2008, showed that the thrombolysis window was now a bit safer, up to 4.5 hours. So there was a little bit more time to play with. Then in 2009, early 2009, I was still working as a house officer, and I was working in a hospital where there was a very passionate geriatrician who was interested in stroke. And this was really where I started to see stroke care taking off. The window was wider, people were starting to do it a little bit more, and they were getting a little bit more comfort and experience about administering it, and the side effects and the benefits, more importantly. But really, the radiology was a non-contrast CT head, and that's all we did back then. Patients would get a non-contrast CT head to make sure they didn't have a bleed, and you would make a decision after that. Later in 2009, I actually ended up working as the stroke house officer in a big hospital in Dublin. And again, was working with another stroke consultant who was a huge advocate for thrombolysis. And again, we're seeing more it getting used more and more. But again, there was still no real defined pathways. And occasionally we had one hospital in Dublin that would do thrombectomies, but very, very infrequently. And still, the radiology was just mostly non-contrast CT heads, very, very infrequently CT angiography. And it was around then I had decided for sure that I wanted to pursue a career in radiology. So in 2010, I actually went to Barcelona and Spain for the European Stroke Conference, because at the time they were going to present a lot of the data on the thrombectomy trials, which had been done up to then, and everybody was very excited about it. We went over and they were all proved negative. So it showed that people who had a thrombectomy, where they went in to intervene and try and pull the clot out, had a poorer outcome overall relative to the people who just got thrombolysis. And for the people who were involved in stroke care, this was pretty surprising, because anecdotally, they were seeing the benefit and response of the patients on the table. Somebody would come in with a debilitating stroke, they would do a thrombectomy, and they would have very little disability afterwards. And there was a meeting afterwards, and everybody was trying to figure out why all these, why the trials were negative, why the data had come out so unfavorably. And ultimately, when they looked at the trials, they had been poorly conducted. Some of them were retrospective. They didn't have very defined criteria of who they were going to include. They didn't have a good biomarker for who they were going to intervene on versus not. And the catheters and the equipment at the time was quite rudimentary. It was quite basic. There was no specific neurocatheters. So the lessons they learned from it and that they talked about was, well, you know what, we need proof to show that there's a proximal large vessel that's occluded. And we need a rapid and effective way to exclude patients with a big established infarct that's not going to benefit from thrombolysis, because those patients will do more poorly. And they needed to have an efficient workflow within hospitals. So right from the ambulance pathways to the patient arriving in ED, to the radiology department in particular, to when they could decide to make a decision of how they were going to recanalize or reperfuse the patient. So the next few years, I was a specialist registrar in radiology in Dublin, and we were starting to see more data on thrombolysis. Still, we were mostly just doing non-contrast CT heads when we were investigating these patients. Very occasionally, we were doing CTAs, and reflecting back on it now, the radiologists really didn't know what we were doing with, or how to read them, or what was important for people to know about. And the big thrombectomy or neuro hospital in Dublin, they were starting to enroll patients as part of a big multinational trial. And occasionally cases were getting sent over. And ultimately, which I only realized after I came back, the hospital that Atu and myself work at actually sent a lot of patients for these trials. So in 2014, I moved over to Vancouver, and I was the neuroradiology fellow over there. And things were a little bit different. There was a little bit more advanced, I guess. We're starting, stroke and cerebrovascular pathology was a major part of the fellowship. You're starting to see firsthand the endovascular thrombectomies, or EVTs. But even there was still no robust data or pathways. There was nothing to support us doing it. And it was really on an ad hoc basis. If there was somebody around, if we thought they'd be a good candidate, but we had nothing to support us data-wise. But on the ground, treatment was absolutely phenomenal. The difference this was making, you would have somebody coming in with a dense stroke, couldn't talk, couldn't walk, couldn't move their arms, and they would sit up off the table and get down off it themselves. It was incredible. And I liked doing them because the patients had an immense benefit. And also when you went to see them the next day on the stroke ward, this was the view you got to see out the window. So these were the lovely mountains in Vancouver, and we had the sea, and it was very nice. This is just a picture of the first thrombectomy clot that I pulled out myself. And again, you just look at that and you see it's one little tiny thing that had somebody who would have been nursing home care for the rest of their life, and now they were mostly functional and independent. So then in January 2015, everything changed and the floodgates opened when it comes to stroke care. And I was still working in Vancouver, I was still the Radiology fellow, but now we had data. And from January to June 2015, there was 4 big trials published, starting with this one in the New England Journal, Mr. Clean, the rest were all in the New England as well. This was published on the 1st of January, and these completely changed medicine in many ways, but particularly stroke care. There was 4 of them. Mr. Clean was out of the Netherlands. The ESCAPE trial was one that in Vancouver we were particularly aligned to because it was run predominantly by a group in Calgary, which is also in Canada. And it had contributions from the main Dublin neurocentre. This guy, John Thornton, is the neurointerventionalist there. And actually Naas Hospital, where myself and Atu worked, we actually contributed a lot of the patients that ultimately formed this trial, which definitely changed medicine. So the second half of my fellowship was pretty busy, particularly with stroke. I was doing a 1 in 3 interventional call. We were in day and night. We were seeing more and more acute stroke, and the ambulance pathways were starting to evolve. Practice guidelines were forming, things were consolidating, and you had pre-alert pathways of what you were expecting, and everything was slicker. We were getting our thrombectomy times down from when the patient came into the hospital. And I always think, looking back on that time period, that pre-January 2015 was kind of like this. You were out, you're looking over your shoulder, you could feel something was kind of happening, you could see it, you knew something was going on, but it was just, the data just wasn't there to support it. And then after January 2015, the wave just came and everybody was taken along on it, and things just changed forever. So what changed? What did the data show? So what it showed was the number needed to treat to have an improvement over control at 90 days. So what they used was a thing called a modified Rankin scale, which is a disability score. And they showed that patients who were intervened on with thrombectomy over patients who just got thrombolysis, you had to intervene on 2.6 patients to have an improvement at 90 days. And you had to intervene on 5 patients to have them completely functionally independent at 90 days. And to put that in context, we use aspirin all the time. So you need to treat between 250 and around 350 patients with aspirin to prevent 1 heart attack. You have to treat about 600 patients with aspirin to prevent 1 stroke. Yet we had a treatment that you needed to treat 5 people to take them from full-term care and disability or death to being completely functionally independent. Very, very few treatments in medicine that we have offered that level of benefit, and that was the real game changer. So when we looked at our trial data, this was from Mr. Clean, they look at the Rankin scale. So you can see up the top here, here's 0, and here's 6, which is death. And ultimately what you're seeing on this graph is the intervention group on the top and the control group on the bottom. And the people who were intervened on, there's much more people in the 0, 1, 2, 3 group than the people in the control group. And the people in the death, the sixth group over on the right, those people we think would have died anyway. Their stroke was so devastating that the thrombectomy, or they were well beyond the window. So we talk about the modified Rankin scale. So what is it? And I suppose the best way to think about it or to explain it is in the terms of going to the toilet or being able to go to the toilet. So if you have a 0, you're like you or I, we've no problems. People with a Rankin scale of 1 can go to the bathroom independently. People with a Rankin scale of 2, most people can go to the bathroom independently. People with a Rankin scale of 3, they need help. They might need help getting to the bathroom. They might need help getting their trousers down. People with a score of 4 are much more in a level of care. They need somebody with them all the time. They need somebody to wipe them, pull their trousers back up again. Somebody with a Rankin score of 5 is severe disability. So they're bedbound, full-time diaper essentially, and 6 is dead. So in when you think of it like that, the benefits were huge. So you were moving more people from high disability level to being functionally independent, and that goes with a huge cost saving from the cost of long-term care, the cost of additional help, support, somebody not being able to work in the family, things like that. And you weren't really making any difference to the people who were in the sick, the people who were going to die. So the big concern would have been that, you know, you take somebody who was going to have such a devastating stroke, they were going to die, and you moved them into a 5, which is bedbound long-term care for the rest of their life, which is a terrible way to be. But that wasn't actually the case. The people who were likely to die ultimately died anyway. And it was the people with the moderate and the severe disability you were moving into a category that they could live functionally independent. But what was really important and what the trials showed was that timing was really important, that all these benefits were great, but the longer you went in minutes, so 180, 240, 300, the longer you went from the time of their stroke onset to getting the thrombectomy on them, the less people that were in the favorable groups. So from a radiology perspective, what changed? Well, it was really the protocols. So we were doing a non-contrast CT, and we're applying a thing called the aspect score, which I'll talk about. We were doing a CTA and multiphase CTA to identify the occlusion and see what the collaterals are like. We're using, some centers were using automated CT perfusion analysis. And there's so much data generated by all this that we're seeing so many patients that you were beginning to finesse the nuances of many of the stroke scenarios, what worked for one person. You were just getting all this data because you were just imaging so many people. The equipment was better, imaging was faster, the care pathways were much faster. And again, the more patients we imaged, the more experience we developed, the more data we had. And when you look back to 2010, the big lessons learned and what they wanted back then, it was they needed a proof for proximal vessel occlusion. We had that. Rapid and effective ways to image the patients and to exclude the people with a big established infarct, and to get an effective workflow. And that's what we'd gotten in just 5 or 6 years. And then, as I said, we had more trials published because we were just getting more and more data to support lots of different scenarios. So these 2 trials were published in 2018, and these were looking at patients beyond the 6-hour window. So in some patients, you could use perfusion or diffusion-weighted imaging to select out the patients who would benefit beyond 6 hours. We'll talk a little bit more about that later. So in Vancouver at the time, what we did was we did a non-contrast CT, we did a multiphase CTA, and we did a CT perfusion with a thing called rapid analysis. And the attitude really was, you just do it. You get the data, you get the images, and you don't delay the treatment decisions. Where we work now, we don't have CT perfusion, but we do non-contrast CT and multiphase CTA. And again, we do it quickly, we do it fast. We don't say no, we don't question it. If there's a query of a stroke, we just do it and we get the imaging and we figure it out later. And why? Why is it because time matters. Time is so important in the context of stroke. And you talk, you know, people publish all these trials of, you know, all this data, and you kind of look at it and it's like everything. And you're looking at big chunks of data and numbers, you know, sometimes they don't mean an awful lot to us individually unless you kind of put it in a personalized or humanized context. And there was 2 papers, one in 2017, one in 2021, trying to do that. And they're kind of sobering enough statistics when you read them. But for every minute saved from symptom onset to treatment restores 1 week of healthy life. Pretty profound. And from hospital arrival to thrombectomy, every 1 second delay was associated with a loss of 2.2 hours of healthy life. Again, it is pretty sobering when you put it in those contexts. So again, the data showed if you had an efficient pathway, you needed to treat 2.6 to have improvement and 5 to have them functionally independent. Again, you compare that with aspirin for stroke or heart attack. So our protocol, what do? We do a non-contrast CT head first, and that's really to exclude a bleed, and to exclude any big stroke mimic, to make sure the patient doesn't have a tumor or encephalitis or anything like that we might see in a non-contrast CT head. And then we try and establish where the infarct is and how big it is, because that'll play a part. And if it's already established and very large, they may not intervene. The Calgary group that was responsible for the ESCAPE trial many years prior to that had come up with this thing called the aspect score, which was the Alberta Stroke Program CT score. And they applied a number to various regions in the brain. There's 10 regions, and you basically you take one number off for every area that you think is involved in a stroke, and you get your aspect score. So 10 is good, it's a normal brain, 1 is very bad. This is from their data. So what they're saying here is if you look at the right versus the left, this person has a left-sided stroke. Caudate nucleus doesn't look quite as good as the right side. The basal ganglia don't look as good as the right side. The insular cortex doesn't look as good as the right side. And this area of cortex here doesn't look as good as the right side. So those 4 areas are involved. That person gets an aspects of 6. This is another case from their data. A little bit harder to see, but they're giving an aspects of 4. So again, basal ganglia a little bit. The definitely insular cortex is gone, and we're seeing a little bit kind of fluffy out here and out here relative to this side. This side here, we're seeing the gyri and the cortex and the sulcal spaces very well. Here it's all edematous and a bit ill-defined. And then the big kind of game changer was the CT and multiphase CTA, and that really allowed us to identify the site of the proximal occlusion and let us assess the collaterals. And the idea behind this is that when you occlude a vessel to your brain, into a particular area, the cells don't die straight away. What happens is most of your brain cells will go into kind of a resting state where they go into their lowest metabolic activity, just enough function to keep the cell alive, but not functioning as a neuron. And so what that means is a lot of patients who have, the stroke symptoms are instant, but they can actually have a lot of tissue that's still alive and has just switched off, and it's kind of hibernating essentially, in the hope that you will get more reperfusion. And different people have very different anatomy and plumbing, and some people have
when I check the blood pressure, they ask
microphone
sorry, Dr. Mark, you could go ahead. Sorry.
All right, you can. People have very different plumbing in their brain, and some people will have a lot of collaterals to an area that will just be good enough. Oh, sorry, I got muted too. Sorry. Don't know how much that cut off there, but I was saying different people will have different plumbing and vascular supply, and even where you have a stroke, some people will have enough blood supply via other pathways to that area to just provide enough oxygen and blood supply to keep the cells alive in their resting state. And if you reperfuse those people in time, you can wake up those cells and save that area of the brain. Some people don't have as good a plumbing, and they don't have as good a collaterals, and larger areas will die quicker. And it's all hugely variable. You just don't know who is going to be the person who's going to do well and who's the person who's going to have a devastating stroke within minutes or hours. So timing is really everything. And with the multiphase CT, essentially what we're trying to do is image a dynamic process and figure out the pathophysiology, but with CT, which is essentially a static set of images. So I suppose the best way I can explain it is by showing you some catheter angiography. So this is a normal catheter angiography, okay? So you can see the blood goes up the MCA, around into the MCA territory, and over the top, okay? And you can see it going from arterial into the venous phase. And I can run that again. You can see the blood arterial phase goes up, and this is starting to go into the venous phase down lower, and that's the way the blood supply goes. This next picture, this person has an occlusion in their M1. Now, to get blood to this area here on the right, you see it has to go up, over, come all the way over the top, and come back down again. And so there's a time delay there, and this person actually has very good collaterals, but somebody else might not. So the idea of multiphase CTA is to image the person. Oops, here we go. So this is these two images back to back, and you're looking at what one hemisphere is doing, and you're comparing it to the affected side. So you get an idea of what that person's kind of baseline plumbing is and how likely they are to have salvageable brain tissue that you could go in and intervene on. So this was devised by this Calgary group who had done the ESCAPE trial, and they did a CTA from arch to vertex. That scan was 7 seconds, and then they did 2 further scans that were about 4 seconds each, and they reconstructed them in 24mm MIPS. And the pearls that they had from their imaging was, from their trial, is that in the first phase, you really shouldn't have any contrast in the dural sinuses, because if you do, that you're already in a venous phase and you've kind of missed the dynamic assessment. You're kind of imaging too late. And you shouldn't really need to sit down at a workstation and painstakingly go through a multiphase CTA. Really, it should be interpretable from across the room, because these are the type of images you get. So the phase 1, phase 2, and phase 3. So it's arterial, late arterial, and venous phase. And the way they use these, you can see there's 3 patients with good collaterals, intermediate collaterals, and poor collaterals. And if you look at the person with the good collaterals, so they all have an M1 occlusion. This person within the arterial phase, after the first phase, the vessels in the left are pretty similar to the ones on the right. Where's my cursor? Sorry. In the second phase, the left is a little bit delayed still, but still good. And into the third phase, then things look fine. The patient with the intermediate collaterals, which is down here, you can see the right side is the control. That's what it should be doing. The left side is not quite as good in that phase, a little bit delayed here still. And in the venous phase, by the time all the contrast is gone from the right side, still quite a bit hanging around on the left. And that's kind of how they judge what's going on. So the person in phase 1 has really good collaterals. They've got really salvageable brain. They will do very well. The person in the intermediate, they will still intervene on. Because they will have an improvement, but they will still have a reasonable stroke. And somebody like in this person with the poor collaterals, they have a big occlusion. They really never fill that territory. And the likelihood is they will have a big stroke no matter what. And if you revascularize that, there's a high chance of bleeding. Here's just some more pictures from various from the literature, and it's mostly from the Calgary group, and they're showing that the patient on the top had poor collaterals at outset. They ended up with a big stroke, a lot of edema. The patient with intermediate collaterals did better, and the person with good collaterals, even though they have an M1 occlusion, a very good collateral flow, and they end up having a very small stroke. And then they say you can take this even further. So we look at these MCA territories here, and this is if you look on the middle image, this flows pretty well. This is a little bit more delayed, and there's still really kind of nothing coming in here. And when you go to the third phase, this side is pretty much the same as the other side, so that's pretty good. This is still pretty delayed, and this still really hasn't gotten any filling at all. So they were likely to have were likely to definitely infarct this area back here, this M6 area, may infarct this area. This area would probably be okay. And when they go on and they do their perfusion imaging and the non-contrast CT, you can see it fills out pretty well, or plays out pretty well, and there's a big stroke in that territory. And initially, when I saw this a few years ago, I was like, can't really use that accurately. And then probably about 2 months ago, 2 or 3 months ago, we had a case in our own hospital with a guy who'd been weightlifting in the gym, had dissected his carotid, and had sent a thrombus to his left MCA. You can see on our multiphase CTA, there's a big thrombus going from the left M1 into the M2 with the arrow there. And he had his thrombectomy, and the next morning, the stroke consultant was reviewing the images with me. And we looked at it and we said, okay, well, this right hemisphere is our control. He's pretty delayed here. He's not really getting anything. This is okayish. This is pretty much the same as the other side. And that holds true when we go to the next images. Okay, so his collaterals here are kind of intermediate to good, but his collaterals up here are poor. And when we MRI'd him the next day, he had a stroke in exactly the area that we said he would from his initial scan before he was intervened on, but all the other territory that was very much at risk was preserved because of his collaterals. So a very powerful imaging technique. If anyone's interested in it, the University of Calgary actually have a lot of test cases on their website. It's the Aspects in Stroke is their website. So onto some more real life cases. So this was a 49-year-old female who had right hemispheric symptoms, and this was her non-contrast CT head. And to show you, she's got a hyperdense right M1, and on her CT head, on her non-contrast CT head, the basal ganglia are a little bit blurred on the right relative to the left, and her caudate's a little bit blurred. So I would have given this an aspects 8 at the time. We have an automated software that's it's hit or miss, but in this case it gave it an 8 as well, so I agreed. And sorry, I'm going to skip that one. And this is her CTA, and you can see in the CTA she's got a big clot sitting in her right her right M1. And then we did her multiphase CTA, and what you can see in her multiphase CTA is that even though she has a huge big clot there, even in phase 1, which you wouldn't have expected, she's already got some contrast coming around, still just beyond where the occlusion is. She's got good collaterals in phase 2 and phase 3. And when we went on to the rest, when you look at the rest of her multiphase imaging, it's a little bit delayed on the right relative to the left, but overall it's pretty good. Those of you who are paying attention, this is actually our case from earlier on today that I was showing you. This is her imaging from her catheter angiography when she went to get her thrombectomy done. And for those who've never seen them before, I've got a few images from her case. So they put a catheter up, a guide catheter up the affected side, and they put it into the carotid. And once they get it in place, they put up a little balloon to keep it in place, and then they use a guide wire to try. You do a roadmap image, so anyone who's worked in fluoroscopy will know you can do a roadmap as a guide for when you're doing any sort of catheter angiography work. So we're able to do that and follow. You can see them trying to get the catheter up her internal carotid, and it's a bit tortuous in her. You can see it kind of kick up there. So you can see they get quite close to here's where the clot is. You're not getting any contrast past that. They park the suction catheter there. You'll see here they take out the guide wire, and then they literally turn on a little pump that provides suction. And then we can see here, this one, they literally just pull it out, and you would be surprised it will pull, in most cases, the whole clot straight back into that catheter. And then you take it out, and then a few seconds later, you take another picture, and you've completely reperfused. And you know, these can be very complicated, or they can be very, very straightforward. She had infarcts in exactly where she had on her early CT, and that's her follow-up CT. That was a 49-year-old lady who would have gone from nursing home to living completely independently. Very, very, very little residual deficit. And that's her non-con CT follow-up. So CT perfusion, I'll just talk about briefly. Not very many places do it, but it's interesting to know. It just gives us some more information. It's always been a very powerful tool. It was previously very labor intensive. Somebody, either the radiographer or the radiologist, would have to sit down and manually process it. And it just was very time consuming. It had to be done at a different workstation. It took a long time. So it was a bit like US politics. You know, you always had people who were very pro CT perfusion and very against CT perfusion, and they would argue at conferences all the time. I actually did neurosurgical grand rounds in 2014 on CT perfusion, and we decided it was good for tumor, for vasospasm, and for assessing vascular reserve. We decided it wasn't useful for stroke because it just took too long to process to be able to make an informed decision. And then things changed rapidly. So a group at Stanford came along with an automated system that would send results directly to an app on your phone within seconds. We have another version now called Brainomics. And this really changed things for places that were doing it. And I'll show you why. I'll show you why in a moment. But what it also did was allowed us to identify those patients that we didn't really think about before, that they look like they have a dense stroke, they have a big occlusion, but their collaterals look pretty good, but they're out of any window to do anything with. They're out of their 6-hour window as it was at the time. And what imaging tests like this showed us was that, well, yeah, they are out of the window and they clinically have a big stroke, but when you actually look at their brain perfusion, there's a lot of brain still perfused. It might just be sleeping and hibernating, but it's salvageable. And it showed us what the actual core of the established infarct was. I mean, what essentially we're trying to do is figure out if there's a mismatch. So if there's an area that's dead, but then is there an area that's salvageable? And I won't really labor the technique of it. There's a lot of things we talk about and we measure, and all these maps get generated, but essentially these are the main ones that we would have talked about: the cerebral blood flow, the blood volume, and the transit time. So really the blood flow is the first pass. So how much contrast gets to an area as the blood gets to an area as the blood washes through. And anywhere there's an infarct, blood flow in the first pass should be reduced. Okay, so it'll drop. So if you block a vessel, the first time blood gets to it, it's going to be delayed. Your blood flow to that area is going to go down. But over the next few seconds, if you have good collateral vessels, you will fill into that territory. So your blood volume in that area, because of the collaterals, may ultimately be normal, or might even be a little bit increased. But if your blood flow and your blood volume go down in an area, that tells you that that bit of tissue is in trouble and it's probably going to die or will die. So here is what the maps used to look like before we had the automated software. And what is showing, if you can see on one of the maps there, the time to peak maps, that the left hand, there's definitely something going on that's taking blood a long time to get there. When you look at the flow map, that same area, it's a little bit reduced relative to the right side. So there is a reduction in flow, but the volume is good. The volume is normal. So that tells us that that area is threatened, but if you go in and intervene, that patient is likely to have a good result and you will salvage that territory. Nowadays, with the automated software from Rapid and Brainomics, we get these different kind of color maps, and essentially they're telling us the same thing. So the ones with the purple on the right are showing what we call the blood flow volume less than 30% of normal. So that essentially means your blood flow to the area is reduced by 70% relative to the normal brain. So that's an area that will die. Okay, so when they look at the data, patients with a blood flow less than 30% volume in an area, almost all of them develop an infarct in that area. And then they use a measure to call it Tmax of greater than 6 seconds. So that's to determine area that the blood flow is reduced and slowed, but that territory is salvageable potentially. And then you'll see down the bottom, there's these figures of the mismatch ratio and the mismatch volume. So when they look at that, they'll say, okay, the bit on the purple we can save, the bit on the green is a much larger volume. There's 14 times as much salvageable as has died by volume. We should intervene on this patient if there was a query. So if this, you know, they wouldn't use this all the time, but if there was a patient who was outside a thrombectomy window, they might use this to decide. Whereas this patient here, they will look at and say, okay, there's a huge area of the brain has already died. That's not salvageable. There's no real mismatch. You know, the mismatch ratio is small. There's a very small volume of tissue to be saved. And if we intervene on this person, we will probably cause them to bleed. So they would not intervene in that. And that's kind of where they use CT. And I have a few real life examples in a few minutes of where that's helpful. I'll skip through these. So this person here had a right M2 occlusion. Their aspects was 8. Very subtle findings on the non-contrast CT. But they worked. They happened to be imaged at a center that did perfusion automatically. And what the perfusion showed was there was no real mismatch. There was this relatively small volume stroke, but it was in a pretty important area. It was in the motor cortex. But the brain already looked like it was dead on the CT, even though they were pretty early. So they had 4 collaterals. There was nothing to be gained on this patient. There was no extra tissue to be saved. And this was just CT afterwards. And it's crazy how accurately it predicts what the infarct core is going to be. This is a second case. It was a 64-year-old guy who was having a coronary angiogram, and he stroked on the table. And his CT showed he had a left PCA stroke. And he went on and he had CT perfusion. And what the CT perfusion showed was this area here in the purple was likely to die. But this area in the green, which it's extended right into his hippocampus and a lot of his memory function and a lot of his visual cortex as well, was potentially salvageable. So they went in and they did a thrombectomy on this guy. And he certainly did have a bit of an infarct as where was expected, but he preserved most of his occipital cortex and most of his hippocampus. And then where it's really, really helpful is in the case of this lady here, the 63-year-old lady. She woke up at 2 o'clock in the morning with acute left-sided symptoms. She was in the west of Ireland. She was over 200 kilometers from Dublin. It was 5:30 in the morning by the time she got to her local hospital on the west of Ireland. She had a CT CTA. Her clinical score for stroke, her NIHS score was 10, which is it's a moderate stroke. And the CT showed that she had an occlusion of her right M1, but she had pretty good collaterals with early filling. So here's her non-contrast CT head, which she presented, which looked pretty good. Here's her CTA, and you can see on the right side, here is her big occlusion. But you can see already, even in her first phase, she's got collaterals filling just beyond that. So she's got good collaterals. And when you looked at the rest of her brain, everything was almost symmetrical. So they contacted the stroke center in Dublin, and they arranged a transfer for her to Dublin, to 220 kilometers to the stroke center. And when she got there, her stroke was pretty dense. So they re-imaged, they did a non-contrast CT head in her. And in the interval of the few hours, she had lost her basal ganglia. So her caudate was gone, and the lentiform nuclei were a little bit more poorly defined. So this is her pre-CT versus her post, her CT a few hours later. So they went on and they did a CT perfusion on her. And the CT perfusion showed that, yeah, there's an area of markedly reduced flow. The flow is down. It's the first pass effect is down. That blood is getting less blood as it washes in. but over the next few seconds, the collaterals are good, so the volume is good, and that blood is all that brain tissue is being kept alive, even though her stroke was pretty dense clinically. So they did a thrombectomy on her, and she has a small stroke in her basal ganglia afterwards and is living independently. So very powerful stuff. And right up until this paper was only published a couple of weeks ago in the Lancet at the end of March. And again, it's showing that in patients who are beyond the typical thrombectomy window, so patients who are living far away, if you have somewhere that's able to do perfusion or multiphase CTA, they're able to select out the patients who are going to benefit from thrombectomy. And they're bringing down that Rankin score from people who are severely disabled and moderately severely disabled down to people with slight to moderate disability, which is huge. So lots of take-home points, I guess. I think the stroke has come a long way over the past few years. And I think it's important to step back and reflect on what has changed and how it has changed. And it's one of these things we're seeing in real time as it changes. You know, you kind of look at the way stroke pathways are here now, and you kind of establish that, you know, you just accept that as the norm, and medical students coming through will accept that as the norm, but it wasn't always that way. And it's important to know what the studies we acquire, what they mean, and the knowledge that they give us to direct patient care. And then to think about the economics of it. Well, it is costly and it is cumbersome to transfer patients around and to have the staffing to run a stroke center. But the alternative economics for long-term care are also huge, so it's important to consider that. And all of the stroke advances of the huge body of data that we have gives a very different knowledge of stroke compared to what it was a few years ago. What we thought we knew, we know things are very different. We know every patient is very different. We know all about the collaterals and how you can't just apply one set of data to everybody. And even though the access to thrombectomy centers is limited, we still give peripheral TPA. It's very safe in windows up to 6 hours. And all the latest data is showing that you can thrombolize somebody, and up to 24 hours, you can get them to, if you can get them to a thrombectomy center within the following 24 hours from their stroke, they can still have a huge benefit. And that's huge in places like in Ireland, where, you know, we've one now, we have two now, we've on opposite ends of the country. But for a long time, we only had one fully operational thrombectomy center. So patients were coming from everywhere. So having the data to support that it's safe to do this is amazing. Obviously, the quicker you get them, the better. But there is window to develop a service in places. And because of our understanding of all the brain blood flow dynamics from perfusion and CT and catheter angiography, it's actually now quite a deal we can infer from the non-contrast CT and even a single phase CT angiography if places aren't doing the multi-phase. Again, we've got enough experience now that we kind of know what's happening and we can infer what's likely to happen. And the big thing really is the timing. The quicker we get people, like we gave those statistics earlier, every minute, say from symptom onset to treatment, restores 1 week of healthy life. And you only need to treat 5 to make them completely functionally independent at 90 days. So even with limited resources, no matter how good the collaterals are, the longer the time to treatment, the worse the outcome will be. Unfortunately, you have no idea looking at somebody if they will have good or bad collaterals. So you need to image as quickly as possible. And yeah, so this is again, these images, you're trying to go from this to this and get somebody independent. So I will leave it there, and I hope that's been helpful or interesting.
Okay, thank you very much, Dr. Mark. We had a very insightful presentation.